nodule, like a single one, or could be multiple nodule, could be cystic in consistency, or could be solid. Later, with the etiology, the nodules can be classified into benign neoplasms, malignant neoplasms, or non-neoplastic lesions according to the underlying pathology. So the question is, why is it important to detect the thyroid nodules? If we compare the data that we have with the adult population, the thyroid nodules in children are reported to be at 2 to 3 times increasing risk of being malignant when compared to the thyroid nodules in adults. That itself raising the significance of taking the matter seriously, because you don't want to miss, at the end of the day, a child presented to you with a small nodule that has been developed into malignancy later on. For the DTC, the differentiated thyroid carcinoma, more often present with advanced disease at diagnosis in childhood compared to adulthood. Usually, the child could be presenting at early age with more lymph node involvement, with distant metastasis, and even multifocal disease compared to adults. For those reasons, we are really concerned and would like to take this matter seriously. The risk of children, for children of a clinically relevant thyroid nodule, which is more than 1 centimeter being malignant, is 20 to 25% compared to 5 to 10% of thyroid nodule in adults, respectively. That means 1 in 4 children with thyroid nodule, they could have malignancy, compared to 1 to 10 or 1 to 20 adults presenting with thyroid nodule. So that is itself carrying a significance with that. So how can we evaluate the thyroid nodule in children and adolescents? Well, palpation is the traditional way. You palpate the thyroid region, and then you palpate the lymph nodes, and then you decide what you're feeling. But also the ultrasound, which is a painless instrument, non-invasive, no radiation, can be done quickly, with the great details of the thyroid tissue, would be of adding value. And in this paper, Jennifer Hess looked at in her work, concluded that the ultrasound is superior to palpation for thyroid cancer detection in high-risk childhood cancer and DMT survivors. And if you look at the receiver operation curve, the ROC here for ultrasound, as well as the palpation, carrying a better sensitivity compared to palpation only. The palpation only ROC area is 0.562, whereas the ultrasound and palpation ROC area is 0.865. So that is self-indicating that the ultrasound is superior to palpation for thyroid cancer, but we're not saying we should not palpate, we just jump and do the ultrasound, but we need to combine both of them, the ultrasound as well as the palpation, to examine patients with a thyroid nodule. A question here is, what is the sensitivity and the specificity of the thyroid ultrasound for distinction of thyroid cancer from a benign thyroid nodule of a child? And the answer on this was found in the recent guidelines came out from the European Thyroid Association, and there is a moderate quality evidence supporting this. If we look at epidemiology of the thyroid cancers, and we know that they can be predisposed by thyroid nodules, look at this study from the US. They looked at the pediatric thyroid cancer incidence and mortality trends in the United States between 1973 to 2013. On this, let me just get the magnifier here. So on this side, we look at between the 1973, the prevalence was about 0.48, whereas after 2006, there was noticed a dramatic increase in the prevalence of thyroid cancer in childhood among the US population. And if we look here, more females are actually having this kind of significant rise compared to males. And then if we look at the ethnicity, it's more common or more prevalent in white race compared to the other ethnicities. So from there, from this SEER study, which is 9 databases being looked at, the prevalence has jumped from 0.48 100,000 persons a year into to 1.14, and that is significant rise. Most affected patients are between age of 15 to 19 years, and looking at the trend here, the incidence of rising thyroid cancer between the two periods, 2006 to 2013, is much higher than between 2006 and 1973. So that could raise a question: what happened? Why there is increasing prevalence of thyroid cancers? One of the possible answers is that more physicians and healthcare professionals these days are performing more ultrasound follow-up for different cases. For cancer survivors, for example, they are undergoing for a surveillance ultrasound follow-ups, and that perhaps is contributing to picking up the thyroid nodules, even if they are small, and therefore diagnosing if there is a thyroid malignancy afterwards. Patients with DICER1 and PTN mutations, they are having frequent ultrasound follow-ups. Depends on the protocols and the practice. Similarly, patients with McCune-Albright syndrome or patients with Graves' disease, they do have kind of follow-up ultrasounds, and that perhaps is contributing to detecting thyroid nodules secondary to these pathologies, and therefore the cancer afterwards. Hiroki Shimura from Fukushima in Japan, they did perhaps the largest study in pediatric population, and this was done in Fukushima Health Management Survey over 3 years, where they got 294,905 participants aged less than 18 years between 2011 and 2014. And this was a time of earthquake, voluntarily had thyroid ultrasound examination in first round of their healthcare system. According to this table, as you could see here, on the left side, these are the male subjects, and on the right side, the female subjects. And here is the detection rate of thyroid nodules. They looked into different things. They looked into thyroid nodules, thyroid cysts, and thyroid cancers, but we here, let's focus on thyroid nodules itself. For the thyroid nodules, what they found is, they found like about 1,415 patients were male with these thyroid nodules in this big study, compared to 2,455 patients were female. So it seems to be the thyroid nodules are happening more in females compared to males. And from here, if you see according to the distribution according to the age group on the left column, so basically what we see here that as the age is progressing, the detection rate is increasing. So it's more thyroid nodules in adolescents compared to young children. Similarly for females. If we look at this graph, this is just describing what I was saying. The females are having higher rate of thyroid nodules compared to males. Let me just use the pointer here to highlight this. Yeah, so you can see here that the females are having higher rate of thyroid nodules compared to males. And if you see here, before age of 10 or 9, there is no difference in the prevalence of thyroid nodules between males and females. So it seems to be something to do with puberty. So after puberty, the rate of thyroid nodules is increasing, and it's more in females compared to males. This is important to be taken in consideration, as I mentioned that later on when we screen patients and manage them. If we look at the lower graph here, this is for multifocality of thyroid nodules by age and gender. For patients who are young, usually they will have a solitary kind of nodule, not multifocal. But as they grow, the risk of having multifocality of thyroid nodules is higher. Um, so here on this graph, if we classify them according to the age group, and we look at the size of thyroid nodules, as I mentioned in this big cohort of patients, what we see here that they tend to be small thyroid nodules in the young age group, but they could be having higher or bigger size of thyroid nodules as they grow. On this graph, adjusted detection rates of thyroid nodules by age and gender for patients who develop thyroid cancer. As you can see here again, the male are the light orange, and the females are the dark orange. So increasing in females' tendency to have it is more than males. In addition, the age. Look, before age of 8, almost none of the patients in this study ended up having thyroid cancer compared to as they grow up. So the age is playing a role here. Saying that for male patients who are under age of 10, male patients under age of 10, they need to be looked at and screened more aggressively, I would say, compared to females younger than age of 10, because they have a higher risk of malignancy compared to females. Now, the question is, what is the prevalence of non-clinically relevant thyroid nodules in children? How many of the children who have thyroid nodules will have just kind of benign, non-clinically relevant, just leave it there. So there is a moderate evidence suggesting that the prevalence of non-clinical relevant thyroid nodules in non-childhood cancer survivor cohort of children who are free of cancer, never been exposed to cancer and radiation stuff, they seem to vary between 0.6 and 2%. So how can we approach them? Now, certain clinics depends on where you are in the center that you are practicing. Some centers, like in Boston Children's Hospital, for example, they do have thyroid nodule clinic dedicated for just thyroid nodules, and it is done as a multidisciplinary clinic run by thyroid radiologists as well and endocrinologists. And the patients, even for children we're talking about, they walk into the clinic with suspicion of thyroid nodule. The nurse will apply a local anesthesia on the skin just before the procedure. So they prepare all their patients to walk in to the ultrasound for possibility of having fine needle aspiration. And if they do the ultrasound on the same time and they found this is ultrasound is highly suspicious, they just put the needle in and they take 4 to 5 samples. It depends on the morphology that they've seen and the pictures of the ultrasound. Usually the procedure doesn't take more than 5 minutes, according to the endocrinologist who was talking about their experience. And so 5 minutes, it's minor procedure, usually done under local anesthesia. No need to put the child to sleep for this procedure. And that's why they have a high number of procedures in Boston. And then their studies showing more information that we could benefit from. Now, risk factors for thyroid nodules. Which patients would be having high risk of thyroid nodules? As we mentioned, the age is one of them. As the child is progressing and growing, there is an increasing risk of developing thyroid nodules. Gender, as we mentioned, in females is higher than males. Exposure to ionizing radiation, increasing the risk of developing thyroid nodules in children. And of course, autoimmune thyroiditis, whether it's Hashimoto thyroiditis or whether it's Graves' disease, there is an increased risk of developing thyroid nodule. Positive family history of thyroid cancer, iodine deficiency, hereditary syndromes like P10, multiple endocrine neoplasia, or DISA, which is multinodular kind of goiter. So these diseases increasing, depends on these gene mutations, they would have increased risk of thyroid nodules. Now, how can we counsel the children and their parents? What are we supposed to say to them? It is recommended that patients with high risk of developing the DTC, differentiated thyroid cancer, based on previous risk factors, so mainly those who have history of radiation exposure to their thyroid gland, or there is thyroid cancer predisposition syndromes like the P10 mutation we just mentioned and the MEN diseases. Those should be counseled for surveillance. And the choice of surveillance modality, whether you do neck palpation as a surveillance every 3 to 6 months, or you do neck ultrasound every 6 months, for example, according to the evidence, this is a result, should be a result of shared decision maker between the physician and the patient. Why we do this? Why we not just say you need ultrasound after 6 months, or you need ultrasound after 12 months, or I'm going to just follow up with palpating your neck every 3 months? This is a dilemma here, or an area of argument. There are advantages and there are disadvantages. The advantages by palpation survey, it's quick, inexpensive, non-invasive, high specificity up to 96 to 100% for detecting thyroid nodule, and especially for large nodule we're talking about. That means many true negatives and few false positives for nodules. Whereas in ultrasound, there are some advantages as well. It's non-invasive, it's higher sensitivity compared to the palpation. It's detecting more thyroid nodules. Okay, there's a higher specificity as well for detecting thyroid nodules that might represent the DTC. So many true negatives and few false positives for nodules. And it can help in detection of the DTC at an earlier stage compared to neck palpation. So there are advantages. But what about the disadvantages? The disadvantage of neck palpation as a surveillance, it has got low sensitivity for detecting thyroid nodule that might represent differentiated thyroid carcinoma. That means we might have few true positives and many false negatives for nodules. Increase the unnecessary invasive procedure due to false positive screening results that we managed to get from the palpation. And detection of the thyroid cancer, differentiated thyroid cancer, at more advanced stage compared to thyroid ultrasonography, because with the palpation, you might not palpate very small nodules compared to the ultrasound. Therefore, that could be leading to increased morbidity, recurrence, or mortality rate. And diagnostic value depending on experience of the physician. So junior physician, perhaps with less experience in examining thyroid, may not detect the abnormalities as a senior physician. Disadvantages of ultrasound. Although the sensitivity and specificity to detect thyroid nodule are high, the diagnostic value of ultrasound for predicting whether a detected nodule is differentiated thyroid cancer is poor. Detection of high number of benign thyroid nodules and small non-aggressive differentiated thyroid carcinomas, which can be managed conservatively. Therefore, if you detect something, perhaps you have a knee-jerk, and then that is increasing the unnecessary invasive procedures due to false positive screening results. Diagnostic value depends on the experience as well of the ultrasonographer and differentiating, for example, between the anaplastic nodule or fully differentiated carcinoma. So overall, the argument is running and going on for whether to do this surveillance, how to do it, neck or ultrasound, palpation of the neck or ultrasound. Generally speaking, there are some advantages of the surveillance if we do them combined. You can detect of the differentiated thyroid carcinoma at an earlier stage. And the early detection means reducing the extent of surgery or additional radioiodine therapy. With that, therefore, the morbidity will reduce. And if there's no cancer, so that would be reassuring. So the intensity of the surveillance or the frequency of the surveillance would be less, therefore less stress on the patient and less frequent follow-up in the hospital. What are the disadvantages of the surveillance? Disadvantage of that is uncertainty of benefit of early detection of the differentiated thyroid cancer, since most of them can be cured even if they are detected a little bit later on, and false positive results leading to unnecessary interventions, such as further ultrasounds or even fine needle biopsy. And that will induce anxiety among the patients and their parents, more stress, more inconvenience, and higher healthcare costs. And especially we are talking about the economy, health economy. So therefore, there'll be lots of waste of resources here that could be arise from this surveillance. And that could represent also risk for complications following unnecessary surgery, for example, damaging to the parathyroid glands following these kind of surgeries. Detection of small non-aggressive DTC, which would never have caused clinical problems, therefore may lead to over-treatment. One of the disadvantages is false negative results of surveillance will lead to inappropriate reassurance of the high-risk patients, and therefore that would leading to less trust into the healthcare system. So that for those reasons, the guidelines are leaving decision to be shared between the physician and the patient after explaining all what we've said. It's a shared decision whether we're going to go ahead with neck palpation as a mode of survey or ultrasound as a modality of survey later on. Now, let's go back guidelines. How shall we deal with the thyroid nodules? I'm sure you are aware of the ACR TARADS. ACR is the American College of Radiology, wrote up for this kind of thyroid imaging reporting and data system according to 5 components: the composition, the echogenicity, the shape, the margin of the thyroid on ultrasound, and echogenic foci. So all of them are based on ultrasound findings, and they gave a score for each of those. And then based on the score, you get the total score for this, and that will be classified into categories to help in detecting whether this patient needs to go for fine needle aspiration biopsy or not. Then the Europeans come up with their EU TIRADS. They modified some of the scores, and they looked into the malignancy risk, as you can see on this table. And then it was published that if you have a thyroid nodule and there's no features of high suspicion, like anechoic or entirely spongiform, so that's benign EU TIRADS, the risk is 0%. There's no need for fine needle aspiration unless it's compressive. Here, it's suggestive if there are some changes, then yes, you need to do aspiration, especially if the size of nodule is more than 2 centimeters. Here, you need to do aspiration if the size is more than 1.5 centimeters, but you have like mild hypoechoic lesions, and that's causing EU TIRADS 4 because of the increased risk of malignancy compared to the other categories. Similarly, if there is at least one feature of high suspicion, therefore you need to proceed with this, and needle aspiration if it's more than 1 centimeter. So the smallest size for fine needle aspiration or biopsy is more than 1 centimeter. Now, remember whether the previous TIRADS, whether the American College of Radiology TIRADS or the European TIRADS, both are based on adults. None of these data or recommendations been validated for pediatrics. And if we talk about the size, relative size of 1 centimeter in adult, that is different from relative size of 1 centimeter in child thyroid. So Gerdy Tully from Italy, with his group, tried to evaluate the efficacy of EU TIRADS and the ACR TIRADS in risk stratification of pediatric patients with thyroid nodules. What they concluded is, according to their cohort of patients, if you look at the EU TIRADS or the ACR TIRADS, the sensitivity, okay, is about similar. The specificity is not that great. Therefore, there are missed malignant cases, about 26.9%. If they apply the EU TIRADS, they could have missed they were developing malignancy. And similarly, for the American College of Radiology, 23.1% of the patients could have been missed malignancy. Look at the unnecessary fine needle aspirations and biopsies. unnecessary in 40% of the cases, unnecessary in 45% of the cases if you apply the American College of Radiology. So it seems to be there is a need for a different scoring system, not necessarily to be just relying on the ultrasound finding. Look at the malignancy in general between the American Thyroid Association triads, about the European triads, and the American College of Radiology triads. There is about a third of the patients that could have missed malignancy. About more than a third of patients here, they had unnecessary fine needle aspirational biopsy. So that's increased the need to have a validated data for pediatrics. In 2022, European Thyroid Association published a guideline for the management of pediatric thyroid nodules and differentiated thyroid carcinoma. Chantal Libnet came up with her colleagues in this wonderful algorithm. And I didn't mention perhaps to you guys that this guideline was done in help of a number of multidisciplinary teams, including pediatric and adult endocrinology, endocrine surgery, pathology, oncology, and nuclear medicine to come up with this. Now, let's go through this algorithm together. If we have a suspected thyroid nodule, it has to do a neck ultrasound and to be done by an experienced professional. And from there, the feature that we see on ultrasound that raising a suspicion, so including the following: hypoechogenicity, calcification, taller than wide shape of thyroid nodule, irregular margins, increased vascularization. So then we confirm this is a nodule, this is not a cyst. Next step is to see what is the size. If it's more than 1 centimeter, based on that adult data that we have, it has been found that it could increase the risk for developing malignancy. So we need to look at the TSH in certain cases here. If the TSH is suppressed, need to move from there to do scintigraphy, because we might deal with an autonomous nodule, and if that is the case, then the hemithyroid needs to be removed. Now, if we deal with cases, slightly different cases, in children with suspected medullary thyroid carcinoma based on family history, for example, for a family history of men, multiple endocrine neoplasia 2, or in case of a bulky thyroid, then for those cases, these individual cases, we might need to measure their calcitonin. And if the calcitonin is elevated, depends on how high is it elevated. If it's severely elevated, it's advisable to remove the whole the total thyroid. If it's mildly elevated, then we just need to move forward for fine needle biopsy. Now, regardless those rarity of the cases, whether it's autonomous nodule or a suspicion of MTC with medullary MTC, medullary thyroid carcinoma, the majority we don't measure the calcitonin or the TSH. If we got concerned nodule, we see if there is a malignancy risk. So malignancy risk, including the ultrasound characteristics that we mentioned earlier. In addition, if there is a history of radiation to the head and neck, plus if there is a history of predisposition syndromes or macrocephaly. So those are considered increasing risk of malignancy in that child with thyroid nodule. If that is the case, is suspicious nodule moving forward for fine needle biopsy. If there's no suspicion, just ultrasound control after 6 to 12 months. So seeing the patients once or twice a year with repeating ultrasound and take it from there, and you just go back into the loop. Now, based on the fine needle biopsy results, the histopathology will detect whether this is Bethesda 1 to 6. And this classification here, as you can see, this helps to make decisions. So if it's non-diagnostic, repeat the neck ultrasound and biopsy after minimum of 3 months. If Bethesda is 2, needs ultrasound surveillance every 6 to 12 months for at least 5 years, and then you go back into assessment of malignancy risk and moving forward. If it's stage 3 or 4 on the histopathology, needs to repeat the biopsy after 6 months. If it's 5 or 6, there's a discussion here whether you need to take part of the thyroid or the whole thyroid. As we advancing in genetics, the question will come up, will molecular testing in fine needle aspiration biopsy specimen of a thyroid nodule in a child help you to distinguish from benign nodules? Now, there's not much evidence supporting this. However, in individual cases, based on the findings, that might be the case. So if ultrasonography was suspicious and you end up doing aspiration and you found this indeterminate histopathology, then for those cases, you might benefit from doing genetics on them. So if the patient is having PTEN or DICER1 or RAS mutation, there is a low-risk molecular profile here. Therefore, only lobectomy will be sufficient and watch and wait approach. Whereas, if the patients with indeterminate histopathology and then found to have RET mutation or BRAF mutation, especially 600, then there is a high risk of molecular profile, and those patients would be advisable to have a total thyroidectomy. And by this, I would stop here and thank you for your attendance and listening. I'm happy to take your questions if you have any.
Dr. Hussain?
Yes.
Dr. Hussain?
Yes, I'm with you.
Thank you very much indeed. Your excellent presentation, but I have one question from the floor from Dr. Shaima Arafat in Alexandria University. She's asking about the incidence of thyroid cancer in Hashimoto thyroiditis, and if you need any screening.
Sorry, can you just read the question again for me, please?
Okay. Shaima Arafat is asking about the incidence of thyroid cancer in Hashimoto thyroiditis, and if we need any screening.
Okay, that's a very interesting question. Yes. Regarding screening for patients in Hashimoto thyroiditis, currently routine screening for thyroid cancer in all patients with Hashimoto's thyroiditis is not universally recommended due to the low absolute risk. However, if they have suspicious symptoms such as a palpable nodule or a rapid gland enlargement, or those with a significant family history of thyroid cancer, or so the ultrasound screening at that stage would be advisable. That's what I would do in patients with Hashimoto's. So not all of them are routinely going for screening for thyroid cancer because they have low risk.
Okay, thank you very much. Do you measure only TSH and calcitonin for assessment of thyroid cancer, or sometimes do you ask for thyroglobulin, etc.?
According to this 2022 guideline, thyroglobulin was not recommended in patients with thyroid nodules, and no strong evidence was found. And for calcitonin, is not, again, the evidence wasn't so. No evidence was found to be done as a whole screening for all patients with thyroid nodules. It's only for patients if you are suspecting medullary thyroid carcinoma, the MTC one. And that's based on individuals, so case by case. If there is a bulky thyroid, for example, or there is a history of MEN2, muscular endocrine neoplasia, or there's a family history of thyroid cancer, the MTC one. So those patients would benefit perhaps of doing the calcitonin levels on them. And the determination of whether it's elevated calcitonin or not, it wasn't that much elaborated on the guideline that published 2022, apart from saying it is highly elevated. So I'm assuming that's multiple times the upper limit of normal range, that is considered as severely elevated, while mildly elevated is not qualifying to that much of rise.
Okay. Thank you very much indeed. Thanks. I think I have another question in the chat. What is the mean of severe elevation of calcitonin? What is the cutoff value?
I thought I just answered this question. So basically,
Yes.
it wasn't determined yet.
Okay. So thank you very much indeed. Thanks a lot. Your presentation was very illustrative. Thank you very much.
Lovely.
Thank you for
Thank you very
joining
much,
us.
and see
Thanks a
you.
lot.
See you again.
Hello.
Thank you.
Thank you. Bye-bye.